Exchange transfusion is used most often for the treatment of HDFN, but it has also recently been used to treat respiratory distress syndrome, disseminated intravascular coagulation, and sepsis. The mortality rate of the procedure is 1%, and it may have substantial morbidity. And it's quantified. The doctor will order a 2-volume or a single volume, which reflects the effect on the infant's total blood volume. The volume that will be transfused depends on the bilirubin levels and the amount and rate of increase of the bilirubin levels. The immediate effectiveness of a 2-volume exchange transfusion in reducing bilirubin levels is 45 to 50%. The plasma bilirubin tends to rise or rebound after an exchange transfusion because of entry of bilirubin from the extravascular spaces and tissues. So if you look at this infant, they're glow in the dark yellow. And that's because once the bilirubin exceeds the capacity of the circulatory system, it then will go out into the tissues. So what happens is once you reduce the bilirubin levels in the circulation, then things go from most concentration to least. So the bilirubin will go from the tissues back into the circulatory system, resulting in an increased bilirubin. And there's also continued production of bilirubin due to maternal antibody coating newly released red cells. Additional exchanges are necessary if the bilirubin level threatens to exceed 20 milligrams per deciliter in a full-term infant. And the target values will vary depending upon the infant's gestational age, because a lot of times these babies that are severely affected are delivered early. Phototherapy is used as an adjunct therapy to exchange transfusion. Infants severely affected with HDFN will require exchange transfusions, and the goals of exchange transfusion are as follows: to reduce the load of accumulated bilirubin, reduce the amount of unbound maternal antibody that's floating around in the baby's plasma, remove antibody-coated cells whose destruction would further raise the bilirubin levels, replace infant cells with red cells compatible with the maternal antibody, which will have a normal survival rate, and replacement with donor plasma restores albumin and any needed coagulation factors. Compatibility testing. The donor blood is usually O negative, and it must lack all antigens to which the mom has immune antibodies. So the reason we're doing this is because the mother has anti-D and the baby's D positive, but if the mother has an anti-Cal, an anti-Duffy-B, and an anti-JKA, the blood must be tested and be negative for all of those other immune antibodies as well. The Coombs cross-match must be compatible. Now, the literature states that the serum or plasma of infant or mother may be used, but at my institution, we always use both. The mother is the best source, as there's a larger quantity available. With newborns, we cannot take more than 3 cc's. If you remember, the hematocrit of a newborn is about 50%. So we're not going to get much serum from that. So we will use that serum to do the antibody screen and the cross-match on the baby. The mom, again, we can draw, as many tubes as necessary to do the testing in the transfusion service. The antibody concentration will be highest in her sample because she's the one that's making it. So again, it's best to cross-match with both the baby and the mother. And the blood must be compatible with both the baby and the mother. So this will prevent any types of errors, for example, choosing the wrong ABO blood group. Again, that's why most hospitals with NICUs, neonatal intensive care units, will only transfuse with Group O. If the mother's blood is not available, use an eluate from the cord cells, which concentrates the antibody. The baby's serum may have a lower concentration. You say, well, why wouldn't the mother be available? Well, we have had babies star-flighted in from rural hospitals who are severely affected. And most of the time, they're really, really good about sending the cord blood sample and a maternal sample with the baby. But in those cases that you don't have that, then you would need to perform an eluate and use that. Using the infant serum or eluate is not ideal, but it's preferable to delaying the transfusion. Selection and preparation of blood, and you need to memorize what is needed for the selection of blood. Citrate phosphate dextrose as fresh as possible, preferably less than 5 days old. We do not use Adsol. Adsol has a lot of chemical components in it that may not be tolerated well by the babies. So remember, blood is drawn into CPD, and then the Adsol is added to extend the shelf life. The hematocrit must be 80% or greater to minimize volume overload. This baby's problem is it doesn't have enough red cells. So what we want to do is really give concentrated red cells. The volume of blood to be transfused during this exchange ranges from 75 to 175 mLs, depending on the fetal size and age. So that's a calculation done by the physician. It must be CMV negative. It must be hemoglobin S negative. Remember, if the individual is a carrier, they're heterozygous, so they're at big S, little s for hemoglobin. Unfortunately, heterozygotes may sickle in the lowered oxygen tension of the newborn. So again, the blood must be tested and be negative for hemoglobin S, and it must be irradiated. This is to prevent what? Graft versus host disease, because there are viable lymphocytes in there, and these passenger lymphocytes may cause GVHD. Preparation of the donor unit, the physician will specify hematocrit. We reconstitute the donor unit with plasma. So most facilities we create neutral blood, so it would be O negative red cells and AB plasma. And we have a formula, I've done this many times, that based on the weight of the packed cells will determine how much plasma you add. And again, the hematocrit is determined by the physician. Once we have the donor unit reconstituted, then we go ahead and send a sample over to hematology to verify the hematocrit as accurate. So this slide illustrates what happens during an exchange transfusion. They don't drain a unit out of the baby and put a unit of blood in the baby. That would be devastating to the infant. So what they do is when the baby's born, they go ahead, instead of clamping off the umbilical cord, they go ahead, well, they clamp it off, but then they cannulate it. And that means they put a needle into the umbilical vein. Then they will pull baby blood. They get a syringe and they will pull a certain amount of blood. Then they'll wait, and then they'll push the donor blood and wait. And they repeat. An exchange transfusion takes at least an hour, if not longer, because we want to do our best to get rid of as many maternal red cells as possible, and again, leave behind donor cells which will have a normal survival, normal oxygen carrying capacity, etc. Rh immune globulin is a concentrated solution of IgG anti-D from human plasma. So during donation processes, they identify donors with anti-D, and they're sent to these places where they do plasmapheresis, and they take that plasma and they harvest the anti-D, so that the only thing in this product is anti-D. A 1 ml full dose contains 300 micrograms of anti-D. I want you to know that. And it counteracts the immunizing effects of 15 mLs of D-positive packed cells or 30 mLs of D-positive whole blood. So if you just remember to multiply 15 times 2, then you can have the packed cell versus the whole blood. It does not transmit infectious diseases such as hepatitis or HIV. They have processing procedures that removes or kills infectious agents. Rh immune globulin is used to protect D-negative individuals exposed to D-positive red cells. This is given prenatally to D-negative moms. It's given postnatally when D-negative moms give birth to D-positive babies, and after transfusion of D-negative with blood products with D-positive red cells. Platelets are really the only product that we will give after giving platelets to. A unit of red cells has too many antigens that Rh immune globulin would be totally ineffective. The IgG anti-D in Rh immune globulin coats the D-positive cells, and it causes their destruction before being recognized by the body. So it's a wonderful product. This discovery has changed the world so far as immunization to the D antigen. So I want to say that one more time. And let's talk specifically about D-neg moms, D-pos babies. The anti-D in this product will coat the D-positive fetal cells that for whatever reason leak into her system during pregnancy, and it will cause them to be destroyed before her body recognizes them as foreign. And the same process applies after birth, which is when the biggest fetal bleed occurs. Rh immune globulin became available in 1968, and this was a major breakthrough. Remember, not all D-negative individuals will form anti-D when exposed to the D antigen, but the majority of them will. And unfortunately, during pregnancy, this is a very, very pathogenic antibody. The first baby will probably be born alive, but after that, the pathogenicity of the antibody increases with each pregnancy, and they will not survive to term. So this reduced immunization to the D antigen from 8% during the first pregnancy, an additional 8% during the second pregnancy, to 1 to 2% overall. So it is amazing. Antepartum or before birth Rh immune globulin administration. It was discovered that D-negative women who were given Rh immune globulin after the birth of a D-positive child were still developing anti-D, and these are termed Rh immune globulin failures. It was determined that small fetal maternal hemorrhages were occurring during the pregnancy, and they discovered that immunization during the antepartum period decreased the risk of immunization from 1% to less than 0.1% if a dose was given at 28 weeks. So determining candidacy for Rh immune globulin is based on testing at delivery. You want to do an ABO-D type on the mom to identify her as D-negative. You must perform an antibody screen on the mom to determine if immune antibodies, specifically anti-D, are present, and ABO-D type on the cord blood. If the baby's D-negative, there's no risk because there's nothing for this antibody to attach to. But if the baby's D-positive, that makes her a candidate. So, women who are not Rh immune globulin candidates, D-negative women with D-negative babies, because there's no risk. The risk is exposure to the D antigen, which a D-negative baby does not have. If the woman is D-positive, she has a D antigen, so there's no risk of her making anti-D. And D-negative women immunized to the D antigen, it's too late for them. Once they have made immune anti-D, Rh immune globulin will be no benefit. Rh immune globulin is anti-D in a bottle, and since she's already making anti-D, again, it's too late. So evaluation of anti-D in the postpartum specimen. Remember, at 28 weeks, women are given a dose, and RHIG is anti-D in a bottle. So women who receive antenatal RHIG may have positive antibody screen. This is why whenever you get a positive antibody screen, regardless of patient type, that you get their history. Because if she has an immune anti-D, then she is not a candidate for postnatal Rh immune globulin. If RHIG is given at 28 weeks, which it's universally done nowadays, the antibody screen will be weakly reactive if the delivery is full term. So an immune anti-D will be 4+. RHIG anti-D will be maybe 1+. It depends how close to delivery the dose was given. So I've seen them, usually no stronger than 1+, and usually it's under the microscope. And R1 cells have more D antigen than R2 cells. So you'll get a stronger reaction with the screen cell that's an R1 than R2. So again, Rh immune globulin is anti-D in a bottle. It's given at 28 weeks. And if she delivers, let's say 30 or 31 weeks, you may have a 1 to 2+ reaction, but no stronger. Do not assume the antibody is immune when the woman has been given Rh immune globulin. And the rule of thumb that everyone goes by is when in doubt, give it out. If you cannot determine whether or not the antibody present, the anti-D present, is immune or not, then give her the Rh immune globulin. No harm, no foul. So evaluation of anti-D clues to distinguish the origin of the antibody, whether it's the Rh immune globulin or the mom. RHIG is IgG. If anti-D is saline reactive, it probably represents active immunization. So saline reactive room temperature, what is the antibody class that reacts at room temperature? IgM. IgM anti-D is not present in Rh immune globulin. RHIG rarely achieves a titer above 4. If you do a titer and it's a high titer anti-D, then that is immune. Obtain the confirmation from physician's records. So what we do is when we identify this weakly reactive anti-D, I call the floor and ask for the date that she received her antenatal RHIG, and I document that on my panel workup, that this is most likely a passively acquired anti-D. What does passively acquired means? That means she didn't make it. That means that this was IgG in a bottle, anti-D, that we injected into her. And again, when in doubt, give it. Administer RHIG if there is any doubt. It won't do any harm, and if this is not an immune form, then we will protect her by getting the fetal cells destroyed in her circulation. I want you to know when RHIG is administered. The antepartum dose is given at 28 to 30 weeks gestation. 92% of women who develop anti-D do so at 28 weeks or later. Obtain the blood sample before administering the Rh immune globulin. We used to have them come to the hospital and we would draw their blood and then administer the doctor would administer the RHIG. Then we would do the type and screen. And in order for her to be a candidate for Rh immune globulin, she must be D and weak D negative and identify the antibodies if the screen is positive. Any antibody other than anti-D, administer Rh immune globulin. Again, Rh immune globulin is anti-D in a bottle. She can have anti-Cal, anti-Duffy, anti-Kid. Matters not. As long as she doesn't have anti-D, she is a candidate for Rh immune globulin. This passively acquired antibody in the Rh immune globulin may be detectable for as long as 6 months after delivery. The half-life is 23 days. 300 micrograms are given at 28 weeks. So about 20 to 30 micrograms are present at delivery 12 weeks later. After delivery, you must inject the Rh immune globulin within 72 hours of delivery. And now they don't allow mothers to stay in the hospital much longer than that. So you have this captive audience to give it to her. Do not delay or omit injection due to problems with antibody screen interpretation. If Rh immune globulin was not given within 72 hours, give as soon as possible. Do not withhold. Let's say the mom left the hospital and for whatever reason they missed giving her a dose. Give her a phone call, have her come back in to get the shot. RHIG utilization gap. Administration of RHIG is indicated, but sometimes inadvertently omitted after several common events. And again, the mother's been identified as D negative. After an abortion or miscarriage, an ectopic pregnancy. An ectopic pregnancy is a pregnancy that the fertilization occurs in the tubes and then the fetus grows and ruptures. And then so she must receive a dose. Antepartum hemorrhage, meaning bleeding at any time during the pregnancy, give Rh immune globulin. Fetal death, also known as fetal demise. Amniocentesis, chorionic villus sampling, chordocentesis. After an external cephalic version of a breech fetus, that's called turning the baby. It's really bad for babies to be born breech with their feet first. So doctors can manipulate the fetus to turn, and after this procedure, you give Rh immune globulin. Or blunt trauma to the abdomen. When you get big at the latter parts of the pregnancy, perhaps the wind blows the car door into your abdomen, or you get hit by a football, or just there's any number of events that can cause a blunt trauma, a car accident. So again, be sure and give a dose after any of these events. So we've discussed who is a candidate for Rh immune globulin and all the situations in which Rh immune globulin must be given. Now we're going to talk about how much Rh immune globulin to give. So that involves detection of fetal maternal hemorrhage. As we've learned, immunization to the D antigen can occur if amount of fetal red cells entering the maternal circulation exceeds 30 mL of whole blood. And this amount is covered by a single 300 microgram dose of Rh immune globulin. The risk of hemorrhage exceeding 30 mL is estimated to be 0.3%. The standards requires that a postpartum maternal sample be evaluated for an excessive bleed, because if there has been an excessive bleed, she needs more of the Rh immune globulin. So back in the very old days, the weak D test was used for screening for an excessive fetal maternal hemorrhage. Fetal D positive red cells would be coated by the reagent anti-D. So again, when you're doing your D typing, you take a drop of the cells, you add a drop of the anti-D, then you incubate, wash 3 times, and add Coombs. And a truly D negative person types as negative. But if there are D positive fetal cells present, they will be coated by that reagent anti-D, and when you wash 3 times and add Coombs, the microscopic evaluation of the weak D will reveal small, tight clumps of red cells, which are the hallmark of mixed field agglutination. So the tiny clumps represent D positive cells versus the sea of free cells or the mother's D negative cells. It's a very insensitive test and requires a great deal of skill and experience. They did a CAP survey, and I want to interject here. Once you enter the workforce, your competencies never end. That's why we do so many competencies while you're with us in the program. So what CAP does, they send out these unknown samples. They know the answers. Labs test them just like they would any patient sample, and they send the results back in. Well, they had a sample with an excessive fetal bleed, and 12% of the labs failed to detect D positive cells in a sample simulating a 30 ml bleed. And having done this test myself. Yeah, it's just due to lack of expertise. You have to know what mixed field agglutination looks like. You need to know the principle of the test. And you have to carefully observe, not just macroscopically, but microscopically. The Rosette screening test, also known as the fetal bleed screen, is similar to the week D. A drop of maternal red cells is incubated with a reagent anti-D, which will coat the D antigens of fetal RBCs if they're present. Then you wash off the anti-D. So the next step is, instead of adding a Coombs reagent, you add D positive indicator red cells, which will bind to the second fragment antigen binding site of the anti-D coating the cells. Remember, IgG has 2 antigen binding sites. This will then form rosettes of D positives around the cells. The test is so sensitive that in response to that failure, a test was developed called the Rosette screening test. It's similar to the week D test. A drop of maternal red cells is incubated with a reagent anti-D, which will coat the D antigens of the fetal RBCs if they are present. Then you wash off the anti-D. Now in the week D test you would add Coombs, but in this test we're going to add D positive indicator cells, which will bind to the second fragment antigen binding site of the anti-D coating the cells. Remember, IgG has 2 fragment antigen binding sites. So we have this one that's bound to the fetal D positive red cell, and the other one is then available to bind to these D positive indicator cells. These will then form rosettes around the cells. They look like little flowers, in my opinion. 1 agglutinate equals 1 fetal cell, and the test is so sensitive that there must be 5 or more agglutinates seen in 5 low power fields to be called positive. So if you see 1 agglutinate or 2 agglutinates or 3 agglutinates, those are not clinically significant amounts. But that's how sensitive it is. It will detect fetal cells that are present, and again, we don't consider it positive until we review 5 low power fields and see 5 or more. This test will have a positive control and a negative control so that you can see what the positive and negatives look like. It's a qualitative test only. It's positive or negative. It doesn't give us an amount. If it is positive, you must perform a Kleihauer-Becke acid elution test to quantitate. Important, if a baby types as weak D positive, a Kleihauer-Becke must be done instead of the rosette. Because remember, a weak D positive has D antigens, so the fetal bleed screen or the rosette test would be strongly positive. So on the left-hand side, we have a picture that illustrates the principle. So you have a yellow cell, which represents the D positive fetal cell. Then that cell has been incubated with IgG anti-D. So that's the black antibody molecule. And as you can see, there is that second fragment antigen binding, which will then bind on to those indicator cells. So on the right-hand side, if you look, I can count 1, 2, 3, 4, 5, at least 5 of rosettes in this picture. And what you do is you spin your tube reader to where they're rolling by. Because they're heavier, because they're agglutinates, they're more easily counted when this is in real life. The Kleihauer-Becke acid elution stain, hemoglobin F, which the majority of hemoglobin present in fetal cells is hemoglobin F, is resistant to acid elution. Adult hemoglobin is not. So what we do is we make a very thin blood smear, and there's a formula to dilute the blood and make this smear. You also run a positive control and a negative control. Negative control, I like to find a male patient, and then for my positive control, they tell you it's usually 1 drop of fetal cells to 9 drop of adult cells, to where that will be your positive control. So controls are crucial for this test. The smears are stained with hematoxylin and erythrocin B. After the staining procedure, first the cells are fixed to a slide. They're exposed to a weak acid solution, and then they're exposed to these two different stains. And adult RBCs, because they do not have hemoglobin F, will appear as ghost cells because, again, the acid elution will cause adult hemoglobin to elute from the cells and the stroma only. So you see these little outlines, these little shadows. The fetal cells will appear bright pink and refractal. And what you have to do is you have one of those counters like when you do retic counts, and you count the number of fetal cells and 2,000 adult cells. Yes, it's very tedious, and yes, you count 2,000. The precision of the test is poor, even in experienced hands. So again, the two pictures illustrates. The one on the left, in my opinion, is a much better representation of the ghost cells. So the Kleihauer-Becke is used to calculate the volumes of fetal maternal hemorrhage. So you must memorize this formula. So what you do first is determine the percentage of fetal RBCs that are present. Then you multiply that number times 50. And 50 is a number that arbitrarily represents the blood volume of the mother at 5,000 mLs. That number is then divided by 30, which will determine how many vials are needed. One vial will cover 30 mLs of whole blood. So let's say that you get the vials calculation as 1.5. You're going to round up to 2 vials and give an additional vial for safety. If you have 1.2 vials, then you keep it at 1 and add 1 for safety, because this test is so imprecise. So here's an example of a calculation. So you count 26 fetal cells in 2,000. So how you determine the percentage is to determine the count by the whole. So 26 divided by 2,000 is 1.3%. So 1.3 times 50 is 65 mLs of fetal whole blood that the baby bled into the mother. Again, one vial will cover 30 mL, so you divide 65 by 30, so you get 2.2 doses. You don't stop there. Don't forget the additional dose for safety. And so this would be 2 plus 1, so 3 vials. You will be required to calculate for the next exam. And I must share this story. I did a fetal bleed screen. It was grossly positive. I did the Kleihauer-Becke, and I calculated the bleed to be, like 250 cc's. How much blood is in a newborn baby? About 200. So what did I do? I immediately looked up the baby's H&H. Baby's H&H was normal. And so what we determined was this baby had been bleeding into the mother probably throughout the pregnancy. And this mom was most likely a non-responder, because even if they'd given her the antepartum dose, which covers a 30 ml bleed, this baby had been leaking continuously. So we ended up giving her, I don't remember how many vials, but yeah, that was an incredible story. But this shows where your critical thinking is crucial, because what if this baby had massively bled? That would have indicated, been indicated by a lower H&H. So it's crucial that you do not compartmentalize. You always remember to tie chemistry and hematology and other areas of the laboratory to the results that you obtained in your department. In the Kleihauer-Becke, false positives may occur if the patient has presence of hemoglobin F due to certain diseases such as sickle cell, thalassemia, acquired aplastic anemia, and several other hemoglobinopathies that you learned about in hematology. The amount of hemoglobin F in these conditions varies in the cell, so the staining is not uniform. So instead of having this uniformly pink cell, you will have gradations of pink color, going from a light pink to a dark pink. Although Kleihauer-Beckys still continue to be done, flow cytometry is slowly replacing them. This technique uses anti-hemoglobin F antibodies to bind, followed by incubation with a labeled anti-antibody, and then they're counted in a flow cytometer. This picture illustrates the principle of flow cytometry using the anti-F to detect fetal RBCs. And I've attached the article to the course that you can read the full explanation of the technique. Finally, giving Rh immune globulin, it's given intramuscularly, usually in the buttocks. No more than 5 doses should be injected at one time. These come in individually prepared 1 ml syringes, so each dose would be given independently. So if she needed 5 vials, then that would be 5 injections. Then if more than 5 doses are needed, you can space them over the 72 hours. Rarely are more than 5 doses needed. But in my example, I forget what the calculation was, but it was more than 5 doses. So she would have gotten 5 doses, spread out just for her comfort. This concludes Unit 11, Part 4, and Unit 11 overall. I hope you've enjoyed it. A lot of information. Really have to use your critical thinking when it comes to mothers and babies. And always remember, babies are 2 patients in one. The red cells are their own, and their antigens are their own, but the antibodies floating around in the plasma have come from their mom.